Welcome to a deep dive into Rick Disler's impactful book, Adrenal Insufficiency, The Symptoms No One Taught You to See. This book from the founder of My Adrenal Life explores how adrenal insufficiency is often misunderstood, leading to years of patient struggle. Eloise, this isn't just another medical textbook, is it?
It absolutely is not, Noah. Rick Disler frames this as a translation effort. He's trying to bridge the gap between how adrenal insufficiency is traditionally taught in medical school and how it's actually lived by patients. It's a critical distinction. He argues that many patients experience what he calls physiologic instability for years, long before they fit the narrow textbook definition of a full-blown adrenal crisis. He also notes this book is intended for educational and informational purposes only and does not constitute medical advice.
So it's about seeing the early, less dramatic signals. The book's subtitle, Dismissed Physiology, Real Patients and the Cost of Misrecognition, really encapsulates that. What does Disler say cortisol actually is beyond just a stress hormone in the casual sense?
He's very clear on this in Chapter 1. Cortisol is a core regulatory hormone required for survival. It's not optional. It maintains blood pressure, mobilizes glucose for brain energy, modulates immune responses, and supports cognition, mood, and recovery from stress. When it fails, it's not a neat shutdown. It's a systemic failure of energy regulation affecting nearly every organ. He emphasizes that healthy cortisol follows a circadian rhythm with ultradian pulses.
And the body tries to compensate, right? But this compensation often hides the underlying problem, leading to these missed symptoms. What are some of those common compensatory mechanisms that make diagnosis so difficult?
Precisely. The body doesn't just give up. It kicks in mechanisms like increased adrenaline output, autonomic nervous system overactivation, inflammatory signaling shifts, and behavioral adaptation. Disler explains these compensations temporarily preserve function, but they come at a cost. They create symptom patterns that look psychiatric, neurologic, cardiac, or gastrointestinal rather than endocrine. That's why he says adrenal insufficiency hides in plain sight.
So many patients are showing clear signs, but they're being evaluated in silos. Rick Disler uses his wife, Christine, as a longitudinal example throughout the book. How does her experience illustrate this delay?
Christine's story is a central thread. Her early years were marked by episodic collapse, pain, blood pressure instability, and cognitive dysfunction, especially under stress. Emergency visits would offer temporary relief, masking the core cortisol deficiency. The book states her experience is not unique, it is representative. This highlights how systems often miss the unifying endocrine driver, treating symptoms in isolation, spanning cardiology, neurology, GI, and more.
It sounds like one of the major barriers is that medicine is trained to look for collapse, not the slow slide into it. Chapter 2 details this, doesn't it?
It does. Disler highlights that medical education emphasizes crisis recognition, low blood pressure, shock, electrolyte derangement. But adrenal failure doesn't start in crisis. It starts in physiology. Nonspecific symptoms like fatigue, dizziness, or brain fog are often reinterpreted as psychological issues. Phyllis's story in the Community Voices section is a stark example. She was told she couldn't be in adrenal crisis because her blood pressure was high, not low, delaying crucial steroid treatment. Appearance also misleads judgment. Patients don't universally look frail.
High blood pressure? That completely contradicts the classic textbook image. So the body's compensation mechanism itself becomes a barrier to diagnosis.
Exactly. The adrenaline surge in compensation can cause elevated blood pressure and a racing heart. This is misinterpreted as anxiety or a separate cardiovascular issue when it's the body fighting to stay upright. Another critical point Disler makes is that normal labs do not always mean normal physiology. Cortisol levels fluctuate, and a single normal result, especially if drawn outside optimal conditions or handled improperly, doesn't rule out the condition if the patient is clearly unwell.
That's a huge takeaway. Let's talk about fatigue, since that's so often dismissed. Chapter 3 calls it physiologic energy failure, not just being tired. What's the key difference there?
It's profound. Adrenal fatigue isn't cured by more sleep or exercise. It's a systemic inability to generate energy due to insufficient cortisol affecting oxygen delivery, glucose supply, and vascular stability. He introduces post-exertional collapse, which isn't just feeling tired after activity, but a delayed, disproportionate deterioration that can take days or weeks to recover from. Patients often say, quote, "I don't hit tired, I hit collapse," end quote. They can also experience autonomic symptoms like racing heart that look like anxiety but stem from catecholamine surges.
So the advice to just exercise more can actually harm these patients by pushing them further into deficit.
Absolutely. Chapter 3 strongly emphasizes this. Deconditioning improves with gradual training, but adrenal insufficiency fatigue worsens when exertion exceeds physiological capacity. Rick Disler's advice is clear: stability must come before conditioning. Otherwise, patients are blamed for noncompliance or told their symptoms are psychological while their physiology continues to fail them. Exercise during illness or instability is specifically cautioned against.
Moving to cardiovascular issues, Chapter 5 discusses how a normal heart can still mean a profoundly unwell patient. How does cortisol impact the heart beyond just blood pressure?
It's a huge point. Cortisol supports myocardial responsiveness, stabilizes vascular tone, helps with sodium handling, and modulates inflammation. When it's insufficient, the heart struggles to function properly even if its structure is fine. Patients might experience inappropriate tachycardia, presyncope, chest tightness, or air hunger. These aren't detectable by standard cardiac tests that look for structural damage, leading to the frustrating reassurance, quote, "Your heart is fine," end quote, while the patient feels anything but. Catherine's story is cited where a doctor dismissed heart involvement entirely.
And the neurologic and cognitive effects sound equally devastating, often mislabeled as anxiety or stress. What's happening in the brain when cortisol is low?
Chapter 6 explains that the brain, being highly energy demanding, struggles physiologically. Cortisol supports glucose delivery, cerebral blood flow, and neuroinflammation. Without it, patients experience brain fog, slowed thinking, word-finding difficulty, sensory overwhelm, and episodes of anxiety or dissociation. Disler emphasizes this isn't psychological, it's neurologic physiology under endocrine stress, quoting patients saying things like, "My brain slowed way down," or "I can't find simple words." This includes issues like visual disturbances and migraines.
So even emotional symptoms are often rooted in physical compensation rather than mental illness.
Precisely. The body's catecholamines surge to maintain vital functions when cortisol is low mimics anxiety or panic. But these episodes often follow exertion, illness, or stress and resolve with rest or steroids, unlike primary anxiety disorders. The book urges clinicians to see this as the nervous system struggling to keep the body alive, not an emotional overreaction. Sensory processing overload is also a key neurologic effect.
And let's not forget the gut. Chapter 7 connects gastrointestinal issues, metabolism, and absorption to adrenal insufficiency. Why is this often overlooked?
GI symptoms are some of the earliest and most persistent. Cortisol regulates motility, mucosal protection, digestion, and glucose regulation. When it's inadequate, patients get chronic nausea, abdominal pain, unpredictable bowel habits, and metabolic instability like hypoglycemia. The most dangerously overlooked reality is variable absorption of medication. If a patient's gut isn't functioning reliably, they might take their steroids, but their body isn't actually receiving consistent cortisol delivery. This highlights the danger of assuming compliance when absorption is variable.
This leads right into the discussion of adrenal crisis, where delays in treatment can be fatal. Rick Disler talks about the slide into crisis. What does he mean by that, and what are the key warning signs that are often missed?
Crisis rarely starts as a sudden disaster. It's a trajectory, a slide that begins quietly. Early signs include fatigue that feels qualitatively different, worsening nausea, new abdominal pain, dizziness, shaking, difficulty thinking, or emotional overwhelm without cause. Disler stresses that this pre-crisis phase, which can last hours or days, is when action should begin, Waiting for textbook symptoms like profound hypotension means waiting too long, as Christine's story and countless others attest. Leslie and Ben's decades of accommodation due to unrecognized symptoms also illustrate this slow slide.
And the book is quite direct about emergency care failures. Why are emergency rooms not safe enough, as he puts it, for these patients?
Chapter 10 is quite stark. Emergency departments are designed for dramatic, measurable conditions. Adrenal insufficiency doesn't always fit that. Patients might not look sick enough, leading to lower triage priority. The most dangerous delay, Disler argues, is waiting for lab results before administering steroids. He says, quote, "This is the endocrine equivalent of refusing insulin to a crashing diabetic until their glucose result returns," end quote. It costs lives. Furthermore, caregivers often recognize deterioration before clinicians, but their input is frequently dismissed.
After diagnosis, the book emphasizes that stability isn't immediate. Chapter 11, Diagnosis Does Not Equal Stability, discusses why patients remain fragile even with medication. What are some of the factors contributing to this ongoing vulnerability?
There are several. The body's been in prolonged cortisol deprivation, so immediate repair isn't possible. Replacement therapy isn't a perfect replica of natural cortisol's rhythmic, adaptive release, leading to peaks and troughs that cause instability. Absorption issues, comorbidities, and ongoing stressors also play a role. Many patients are diagnosed, given a prescription, and sent home without the critical education needed to navigate the reality of their new condition. Disler stresses, quote, "Medication is necessary, education is life-saving," end quote.
This vulnerability then leads into the concept of complex adrenal insufficiency, where even with adherence, patients remain unstable. What does this mean for both patients and clinicians?
In Chapter 12, he explains that complexity is not failure. It means physiology doesn't fit the standard model. It often stems from unreliable cortisol delivery due to absorption issues, imperfect timing of doses, or other chronic conditions altering cortisol's use. He argues that instead of asking, quote, "Are you taking your medication correctly?" clinicians should ask, quote, "Is your body receiving and utilizing cortisol predictably?" This shift is crucial for collaborative problem solving instead of blame. This complexity also applies to patients whose baseline is severely limited even after diagnosis, as discussed in Chapter 13 on disability.
And the emotional toll of all this, including the impact on caregivers, is immense. Chapter 14 acknowledges caregivers as the other half of the illness.
Rick Disler, as Kristen's primary caregiver, speaks from direct experience. Caregivers often live in a state of constant readiness, recognizing subtle changes before anyone else. They become first responders, advocates, and medication managers, experiencing their own chronic stress and trauma from systems that hesitate to act. He urges that caregivers are critical clinical functions, not just support roles, and deserve acknowledgement and education. He stresses that caregiver burnout is a predictable clinical reality.
Finally, the book culminates in Chapter 15. What needs to change? What are Disler's main calls to action for improving adrenal insufficiency care?
He calls for change across 3 domains: clinical practice, healthcare systems, and medical culture. Clinically, he wants AI taught as a spectrum condition, emphasizing volatility over just hypotension. Recognizing normal labs don't always mean stability, and validating neurologic and GI symptoms as physiologic. Systematically, he advocates for treating hydrocortisone like insulin emergencies, standardized diagnosis day care, which should cover immediate education and emergency protocol writing, and reducing access barriers. Culturally, he stresses moving away from psychological labeling, replacing dismissal with curiosity, and honoring lived expertise. He also emphasizes that recovery is not always a return to previous capacity. Disability is a real possibility that must be acknowledged with compassion.
It sounds like a profound and necessary critique, grounded in patient experience, but aiming for systemic improvement. Rick Disler's Adrenal Insufficiency, The Symptoms No One Taught You to See, certainly offers a new lens for understanding this complex condition.
It's a powerful and essential read for anyone connected to adrenal insufficiency, whether patient, caregiver, or clinician. His closing message is, quote, "You should never have to earn the right to be believed," end quote, which really encapsulates the book's heart. And the book provides appendices with practical tools like the red folder system and the exercise safety guide, reinforcing that stability must come before conditioning.
If you found this conversation insightful, consider sharing this episode with someone who might benefit from a deeper understanding of adrenal insufficiency.